Everybody? Did we miss? Monday. Here we are. Week 12. Week 12. We're grinding it out here. Let's say a prayer and then talk about what's happening this week. And the Father, Son, and Holy Spirit. Amen. Frosty morning, but it's like it's gonna be a beautiful day. Thank you for that. Thank you for the gift of seasons. Help us this week. Things are busy. Again, so just help us work hard, help one another. Get to the end here. Say a special prayer for anyone who's sick, suffering, those who are dealing with loss. Just raise them up to you, give them comfort and strength. Oh gosh, we thank you for all your many, many blessings, Lord. Help us just walk throughout the day, noticing all those blessings. Amen. Okay, this week, what are we doing? We're doing all things Jesus. And in class this week, we're going to continue that theme. Like Angie, Austin, Peter, enteral feeding, and TK, which I think is probably talk about in nutrition a bit, but we'll kind of tell you how you do that with the actual apparatus. So it's a busy lab. And we're going to say, Thursday people, bless you. Thursday people, especially my afternoon people. I need you to be coming to my Thursday morning lab. We're going to have one full lab Thursday morning. We're going to split up, hopefully use Sim Lab and the Skills Lab so that we have room to practice these skills and also do Sim. Okay, if that doesn't work for you, can you let me know? I know there's that doesn't work for, so I'm going to try to record myself probably on Tuesday's lab so that you'll have how to do it. Of course, you have API as well. Yeah, and then with lab, I just thinking of, and it zipped out of my head. Oh, Tuesday's group. After the morning lab, I need a few of us to go out to the parking lot. Have you seen the mobile health unit? That's ours. That's ours. Isn't that so cool? It is from a sweet lady who donated it. She did not go here, but she was a nurse. She left us money. And we have been dreaming of like a little mobile health unit for many, many years. So it was put into effect and we have it. Now we just have to learn how to drive that sucker. Yeah, so that's what Professor Brosnan and I are going to do this summer is to see us around in the campus. Professor Brosnan knows how to do that because she does. She has a horse trailer, but when it lands, it's been a while since I have had to back up anything like that. So that's what we're going to do, and then we're going to take it on the road. And then you guys get to come. and do clinicals, maybe in places that don't really have any access to healthcare. Make that happen for us. So anyway, we're gonna announce that we have this wonderful gift. We need pictures. I need people in their purple scrubs after Tuesday's lab to meet the marketing team, to take pictures. Okay. That should just take a few minutes, but we'll go out there and snap a few shots. So be sure to have your scrubs on, of course, yeah. Isn't that exciting? Sweet. If you have ideas on how you think we should use it, let us know. Pretty excited, pretty grateful for that. It's a very generous thing. A very unexpected surprise. Okay, so pictures, Thursday's lab. Yeah, gonna be busy, but good week this week. You have a choice today. Because it's gonna overlap, what we're talking about today is more like oral, intestinal type things. And then stomach on Wednesday. So you'll wanna come on Wednesday. Just saying. But today, do you want to begin with a study guide? You have to fill it in groups. Or practice questions. You can do practice questions today. You can do the study guide on Wednesday. You can do the study guide today. Practice questions Wednesday. Okay, raise your hand if you want to do study guide today. Okay, looks like the majority. Okay, we'll do study guide today. And then you will want to come on Wednesday. Just saying. So let's do that. Okay. Gotta get more tea in my little brain to get like thinking, let's do this. Okay. How about we just count off? That's fun. 1 through 15. See how many parts. 1, 2, 3, 4, 5, 6, 7, 9,
10, 11, 12.
13,
14.
14. Awesome. Awesome.
2, 3, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 1, 2, 3, 4, 5, 6, 7, 8.
Awesome. Okay, number 1's down here, number 2's here, number 3's here, number 4 is here. It is. 5, 6, 7, 8. You can make our way all the way up to the top. So just designate yourself. I'll open it up. Who's not? 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Okay. Hop on to the old people. Oh, slide. DI, Google Docs, study guides, something like that. You see it? Yes. No, yes. Okay, so group 1, you're taking Two, what do you do? Oral cancer, three,
Hiatal hernia.
hiatal hernia, which is different than other kind of hernias, good. And four. Gastritis, okay, five. Is that my five group, Katie?
Yeah.
Okay, everybody fine on what you're looking for? Okay, all right, so take a few minutes to fill that in best you can. Try not just put into chat GPT, let's try to actually fill it in.
Oh.
Amongst one another.
It's okay.
Yeah.
Bye. Is there anything that we're missing? You know what we can do? Who's my number 8? You guys are gonna do Crohn's. You guys are gonna do ulcerative colitis, so that will be under 8. You see that?
Yeah.
Okay, awesome, thank you. The bottom of your little section, you'll see NCLEX questions. I want you to create 2 NCLEX questions that you think would be asked about that condition.
I think it's just part of what I saw.
Goodness, minutes, I need some vitamin D brought in, right? Sorry. A sniffling. My number 9 group. 9 group.
I know. It's just like, what would you do? What should we?
Couple more minutes, start going through.
Yeah, you're right. Yeah. I got hernias, IBD,
Oh, I
appendicitis, colorectal cancer, and test section. Oh, it's. Yeah, but yeah.
Is there a lecture video for Wednesday?
No, not really, all the. It's just gastritis. Typical sensitivity and gastric cancer. So more of some. Yeah, yeah. I think it was one slide, but it didn't.
Okay,
Talk about it. It just says like intestinal. It's all those slides. Yeah. Yeah. I love best way to learn.
Yeah.
15 different things.
Yeah.
Slice and cheese, okay. Yep.
I guess 17.
How are you doing?
Yeah.
Okay. Isn't that awesome? You have 20 pages worth of a study guide. Okay, so let us, you can stay right where you are. People, I'm gonna call on you to walk us through these different conditions as we kind of go through them on our practice questions. But to begin with, we're just gonna go through some general type questions and do this all below. Right. Can you see that? Joe. Okay, here we go. GI practice questions. So anatomy, we're talking from the rooter to the tutor, all the way through. Mostly, for us, we are not spending a lot of time on the liver. That's what you'll do in 404. Because that big old book that you have. That's Rosin and I split it up. So I take a portion of GI, she takes the other portion of GI. So liver, like hepatitis, cirrhosis, that kind of stuff will be covered next semester, along with gallbladder issues. Yeah, those kind of things are in 404, but everything else is ours. So sorry, we have a 20-page. All right, so some terminology that we just need to familiarize ourselves with. Peristalsis, what is that? Peristalsis.
It's like the way movement for your intestines.
Yeah, it starts in our esophagus, really, right? And then it goes all the way through our stomach into our intestines. That's how food and drink move through. Without it, things would get stuck, right? Like blockages would occur. So remember that for like our post-surgical patients where peristalsis is diminished. Why we give certain medications that we'll talk about here in a sec. What is hematemesis? Heme is blood in the vomit, right? So that is a serious thing. If you see bright red blood, vomiting, or through the NG tube, you should take note. Things can get real bad real fast. Okay, coffee ground emesis. Anybody seen this? Smelt this? It's a very unique smell, just like melena is the next thing. It smells like iron. It's blood. That's what you're smelling. And it looks like coffee grounds, literally, like if you put an NG tube down and all this black specks are coming out. You smell it, it smells like iron, you're like, coffee ground emesis, it means that we were bleeding at some point. Usually from the upper GI portion. And now we're seeing it either that they vomit out or that we suction out. Okay, so coffee ground emesis means you're bleeding before. Hematoemesis is active bleeding, right? Melena is black tarry-like stool. Kind of think back to when you saw your little babes, they have meconium. Kind of looks like that. Is dark black. Related to blood in the stool. So again, what's happening? Previous bleeding. Can be from the upper, can be from the lower. So that's not as distinguishable. It just means that somewhere along the way we had bleeding and now we're seeing it in the stool. It also has that iron-like smell. Okay. So take note of that. And tell me the difference between an ostomy and a stoma, because you'll hear people use those terms, but they I don't know, they use them for each other, but they're actually two different things. What is ostomy? I want to see you guys in different sections. I'm like, I don't know where to be looking here. Lay it on me. Ostomy. Yeah, you. Good job.
It's the ostomy, the like actual surgical incision made through the abdominal wall, and the stoma is like the part that's gonna be raw.
Yeah, good. So did everybody hear that? So the ostomy portion is actually the surgical incision, the procedure itself, where the stoma is the intestine brought forward, right? That's most what we're talking about. So what was it supposed to look like? If I take my intestine and bring it to the surface of the skin, what should it look like? It's your job to be looking at that. Miss Grace, what do you think?
Should be
Should be pink.
moist.
Kind of moist, yeah, not dry, not black, not purple, not white, it should be pink. And if it's not, you're letting the docs know, right? Because we worry about reduced blood flow to that area. So any other change in color would be like, hey, maybe something's happening and they could get necrotic bowel. Life threatening. Awesome, good deal. Moving around. Medications. So almost every condition that we talk about has the same choice of meds. So we just have to remember them. You learn these in pharm, so this will be a little review for you, okay? I think, I don't know, you tell me if GI is more straightforward than some of the other systems that we talk about. Antacids, what do antacids do? The name says it. Acid. It's against the acid. It neutralizes acid. Okay, so this is us taking Tums after we have, I don't know, Mexican chocolate and coffee, right? And we're having like reflux. Ugh. Right? I'm taking an antacid, which is aluminum hydroxide, magnesium hydroxide, or calcium carbonate. A PPI. What is a PPI? Proton pump inhibitor inhibits acid production. Okay, so this is your Zols, omeprazole, lansoprazole, pantoprazole. Have you seen this in clinical? I would guess a lot of your patients are on PPIs. We generally put someone on it when they're in the hospital because they're under stress. They have increased acid production. They're at risk for ulcers. So we put them on PPIs when they come in. H2 blockers, very similarly, they block stomach acid production, just in a little bit different way by the histamine receptors. And these are your deans. So cimetidine, ranitidine, famotidine, Pepcid, another name, right? Very, very common. You can get these over the counter. Laxatives. Laxatives promote bowel movements. So this can be like psyllium powder. Could be tablets. Osmotic laxatives, so that's magnesium hydroxide, or stimulant laxatives like bisacodyl. Have you seen bisacodyl? Like some tiny pill people will take. So sometimes we are addressing motility and like moving stool out from the top. So giving bisacodyl and from the bottom, doing enemas. Okay, so we're going from both ways, trying to move things through. Laxatives are good for a short term. But if you have to rely on them every day to have a bowel movement, we do not want that. Right, so you have to ask your patients about laxative use. And antibiotics could be used to treat any kind of infection within the GI system. Antispasmodics, so that relax muscles of the GI tract. Antidiarrheals. So loperamide, bismuth subcislate, what is that called? Over the counter. It's pink. Pepto-Bismol, awesome. And anti-nauseants, is that even a word? Is it? Anti-nausea medications, okay. Prevents nausea and vomiting. So this is like your Zofran. Ondansetron. Zofran's a little easier to say. Okay. And then metoclopramide is actually a motility drug, but it helps with nausea as well. Sometimes we give that to increase peristalsis. Okay. That's why they are nauseous. So that's it. Those are all your meds. You gotta memorize those suckers. Because every condition, we're probably gonna use one of these. All right? Questions? All right, before we get to this, where are my GERD people? Number one, you wanna walk us through? I'm not bringing it up, you can just talk us through, what is GERD?
GERD is a chronic disorder that describes a variety of clinical manifestations without tissue damage caused by acid reflux from the stomach and the esophagus. Reflux occurs when the lower esophageal sphincter is weak and relaxes inappropriately, causing a pressure gradient between the lower esophageal sphincter and the stomach to be lost.
And what does that mean? As well read. What does that mean? Have you all had GERD, people? Have you all had reflux? Is where your stomach acid moves out of your stomach and comes up your esophagus and you have heartburn. That's what we're talking about. But GERD is actually a kind of constant or consistent state of having that happen. Not just sometimes when we're nervous or depending on what we eat, when we have reflux. This is like a condition where we can actually get changes onto our esophagus because of the stomach acid. So this is important. It's kind of loose stomach acid. We can kind of get through there. We lay down, that can happen after eating. So all these things, if you understand like the anatomy and what we're talking about, you can understand the interventions, right? Next. Keep going.
Manifestations, heartburn, regurgitating acid, inflammation of the esophagus, and chest pain.
Yeah, sometimes when people are coming in, they're like, oh my gosh. It's like a knife stabbing me in the chest. You're like, oh geez, are we talking about GERD? Are we talking about an MI? Do I want to be wrong? No, they're having an MI, we gotta be addressing that. So what do? We usually give them Maalox. Like, here's a little Maalox, take it on down. That helps resolve some of that. You know, it was GERD, heartburn, rather than MI. We're still working towards the MI stuff, just to be on the safe side. So we always try that as well. Okay, awesome, keep going.
Diagnostics, GERD symptoms, which are a UTI, and that would cause resolution. And then you can also do a 24-hour ambulatory esophageal pH monitoring.
24 hours esophageal monitoring. I don't know how they do that. Let me just think about that. How do they do that? No idea how they do that. Like the person who's walking around getting their pH checked. No. Oh, we'll go back. Yeah,
I just Googled it and
Okay.
it said they use like a flexible catheter tube and like kind of like an NG tube and like esophagus and they're measuring it. So it remains in for 24 hours and they can like pull and test acid.
walking around with Benji, keep pulling out stomach acid every so often, checking pH. I like it. Okay. I got it. Awesome. Keep going. Next.
Next, management medications,
Okay.
which are antacids, histamine receptor antagonists, prokinetic medications, proton pump inhibitors, and then a surgical management would be laparoscopic Niacin
So
fundoplication.
fun. Okay, we'll talk about that. We'll talk about hiatal hernia. Okay. Awesome.
Keep going.
Yeah, so did
Okay.
everybody get the meds, antacids, PPIs, and H2 blockers? You're gonna hear that a lot. Awesome.
And then assessment would be respiratory symptoms, regurgitation, gastric contents, chest pain, hemorrhage, CBC, dyspepsia, dysphagia, signs and symptom of Barrett's esophagus, dental caries, water brush, bloating, nursing diagnosis, acute chronic pain, risk for aspiration, impaired swallowing, and relative nutrition interventions be the same medical management. Position patient on the right side with head of the bed elevated 6 to 12 inches, and then also eating small meals. Teaching, educating on limiting foods that are spicy, fatty foods, caffeine, chocolate, carbonated beverages, alcohol, medications, certain medications. Avoid smoking and alcohol, avoid NSAIDs, aspirin, avoid tight clothing, and avoid eating meals late in the day or 2 hours before bedtime.
Good. So all that education is good. Let's start that.
And then just evaluation is just making sure that, or the patient is making positive lifestyle changes and diet modifications. Or seeking medical attention if they develop clinical manifestation, and then also just the group will get better.
Great. You're hoping that it will get better. They experience it less often. Good. We worry about over time that could cause damage to the esophagus, which could lead to bleeding. Bad, and types of cancer, esophageal cancer. So it's not something totally benign. We do want to address this. Okay, so good education piece on that, what we can tell our patients. You, alrighty, and your NCLEX questions, lay it on me.
All right, selecting medication classifications that are indicated for management of GERD. Proton pump inhibitors, antihistamines, antacids, antiemetics, histamine receptor agonists.
Okay, you tell me. Antacids, was that one on?
Yeah.
Okay, run through it again. Just say one at a time.
Proton pump inhibitors,
Yay or nay? Yay, okay,
antihistamines,
now,
antacids.
yay,
Antiemetics,
nay, okay.
histamine receptor agonists.
Yeah, that's H2 blockers. Awesome. Okay, next one.
The nurses reviewing teaching points for their patient with GERD, what would they want to?
My gosh, this is like you read my mind. 2 points. Yes.
Patients should avoid taking NSAIDs and aspirin.
Oh. Yes, Good.
Encourage avoiding meals late at night.
yes,
Body weight has no effect on GERD.
false,
Peppermint and chocolate might worsen GERD symptoms.
true. That's it. Good job. Well done. Okay, awesome. Which of the following nursing interventions should the nurse perform for a female client receiving enteral feedings through a gastrostomy tube? All right, so see this little tube that goes in our belly here? Tiny little tube, up into the stomach here. About this long. You know how they place this little thing? I think I told you this. Okay, they go down and let this go. Through your esophagus. Into your stomach. And then they shine a light through. a little flashlight from the inside. You see a little glow, they make the incision right there. Pop her in. That's how it's done. I'm like, what? Like the little flashlight through your hand kind of trick is what they are doing. Put that in. Okay? Usually held into like a little disc or balloon, hold it in place. Okay? And this is how we can give meds or enteral feedings without having something in their nose or going down their mouth. So this is probably more long-term. Okay. All right, so which of the following nursing intervention should the nurse perform for a female client receiving enteral feedings through a gastrostomy tube? Change the tube feeding solutions and tubing at least every 24 hours. Maintain the head of the bed at a 15-degree elevation continuously. Check the gastrostomy tube for position every 2 days. Maintain the client on bed rest during feedings. What do you think? Tell me 1, 2, 3, 4. One, two, three, or 4. Smart. Look at it. Change the tube feeding solution to the tubing at least every 24 hours. Yes. We don't have it sitting there like a little cesspool, like, you know, it's got dextrose and lipids and all this sort of things sitting in there. It just comes from a can. It's like you drinking a can of insurance. That's what tube feeding is. Okay, so we have to change that out or it can grow things. Maintain the head of the bed at least how high? 30. Good job. Check the gastrostomy tube for position every 2 days. How about Q shift? Q shift, you're making sure that it is working well, right? Not really checking position, it's just, is it working? And maintain the client on bed rest? No. Preferably, we'd want them up in a chair. Awesome. Your patient has a GI tract that is functioning. Okay, but has the inability to swallow foods. What do we call that? Dysphagia. Which is the preferred method of feeding for your patient? TPN. Thickened foods. NG, enteral feedings, or oral liquid supplements. What things could you get rid of right away? Your patient is unable to swallow food. Are we going to give them food? Now, so get B out of there and B. Now we're down to TPN or NG enteral feeding. First part of that statement is feel. NG, enteral feeding? Yeah. Yeah, when would we decide for TPN? Right, if the GI system is not functioning, you can't be putting anything in it for absorption. Good, awesome. While a female client is being prepared for discharge, the nasogastric feeding tube becomes clogged. Bummer. To remedy this problem and teach the client's family how to deal with it at home, what should the nurse do? Irrigate the tube with warm water, advance the tube into the intestine, apply intermittent suction to the tube, withdraw the obstruction with a 30 ml syringe. What do you think? Guesses? What? Yeah, we'll try to irrigate with warm water first. You can try to pull back, see if you can get it, but first we try to just like gently apply some pressure, not a lot of pressure, but a little warm water to go through there. This is why we have to do kind of similarly when we give IV meds, how we do saline, administer saline, we give 30 mLs of warm water before administer whatever we're giving, and then 30 mLs afterwards, so we do not have clogging of the NG tube. It is a bummer to have to replace an NG tube and block it off. That's on us, not on our poor patient that has to suffer through that. Okay, so flushing before and after is important. Okay, Advancing the tube into the intestine is for a Dobhoff. That's a little tube feeding that sits in the intestine rather than an NG, which sits in the stomach itself. And then apply suction to the tube. We could try that, but that's kind of like trying to withdraw it manually as well. But first, warm up. All right, throw in a little ABT. A client presents to the ED reporting that they have been vomiting every 30 to 40 minutes for the past 8 hours. Bummer. Frequent vomiting puts him at risk for which of the following? Metabolic acidosis with hyperkalemia, metabolic acidosis with hypokalemia, metabolic alkalosis with hyperkalemia, metabolic alkalosis with hypokalemia. You're losing stomach acid. Start there. We have acidosis or alkalosis. Alkalosis. And in that vomit, we are losing potassium. So metabolic alkalosis with hypokalemia. Guys, just a few weeks ago, you didn't know ABGs? Yeah, you did. Okay. Oral replacement solution for children. All right, so your little infant has sunken fontanelles, loss of skin turgor, indicating moderate dehydration following 2 days of vomiting. The client weighs 8.5 pounds. What would you calculate for oral replacement for this patient? You know this? Okay. Let me see if I can pull it up. Pediatric oral replacement. Or needle. Find it for you. This is not what I need. Okay. Okay. Generally, 50 mLs per kg is given over 4 hours for mild dehydration and 100 mLs per kg for moderate dehydration. So, what's our little patient going to receive? Mild and 100 mLs per kilogram. Moderate. Our little patient weighs 8.5 pounds, so how much is that in kilograms? 4. 4.3. Oh, 3.9. So 100 times 3.9. We can give that to them orally, preferably, but if they are not able to take that, we can keep it in. So if I give you a little problem or something, you can do that on a test. Yes, Professor Johnson, yes, okay. Polyethanol glycol electrolyte solution, GoLYTE, is prescribed for the female client scheduled for a colonoscopy. The client begins to experience diarrhea following administration of the solution. Which action by the nurse is appropriate? Start an IV infusion, administer an enema, cancel the diagnostic test, explain that diarrhea is expected. Yes, diarrhea is expected. I have told you that in fundamentals. Remember, my little patient was like, he came in for his colonoscopy. He was like, I have diarrhea, so I stopped taking it at like 2 a.m. I'm like, oh, sure, you're gonna have to do that again. We don't gotta go for this test. Have you guys gone to endoscopy yet? Have you seen what it looks like? If there is stool, you can't see anything. You see stool. So doctors won't do it unless you're clear, meaning that you are pooping water. That's what we're looking for. Okay, so we have to tell our patients that diarrhea is expected. That's exactly what we're wanting. Awesome. Okay, true or false? Following a barium swallow or barium enema, it is common that the patient may experience constipation. Have you seen this? Have your patients gone for a barium anything? So barium is just like a chalky white solution that they will either drink or they will get as an enema. And it will just bind them up. So we need to promote fluids afterwards, to keep that moving through, or they can become constipated or obstructed with barium. Seems like something we should know. We can prevent. All right, gastric cancer, we're gonna come back to, so my gastric cancer people, not forgetting about you, I will talk to you on Wednesday. Hernias, let's go there. Who is that? This is not hiatal hernia, this is hernias. You guys hernias? Okay, all right, lay it on us. What are hernias?
There are protrusion of abdominal contents through an area of weakened muscle in the abdominal cavity.
Okay, where can these happen?
They can occur anywhere in the body, frequently occur in the abdominal cavity, with the protruding through the abdominal.
Such as, your pregnant mamas, you probably saw this. Where do they get little hernias happening? You did little belly buttons sticking out. Yeah, like an umbilical hernia. Like a little baby's in there, you guys, like 10 pounds something, 9 pounds something. Everything's pushing things out. You got a weakened abdominal muscle, even though you like worked on your core for how long? Opens up, you got a little intestine sticking out. Like, oh my gosh. Oh, beautiful, right? Yeah. Okay, so you have this little umbilical hernia. Is that a big deal? How do we know it's a big deal?
Although reducible and irreducible.
Awesome, so reducible means I can push it back in. If I can't push it back in, irreducible. You might hear carcerated or incarcerated. Seems extreme, I don't know what that means. Okay, so basically, can I move it in or out? If I cannot move it in, I worry about blood flow being obstructing that piece of intestine that's coming through. Okay, that's what I worry about for all of this. Get reduced blood flow and we can get necrotic bowel happening there. Okay, so this is something we have to pay attention to. Yeah.
When you push it in, does it come back out?
Yeah.
But it's just like it.
Mm-hmm. But yeah, just right there. And it might stand for a little bit and then. Okay, so that's umbilical. Where's another place that can happen? Yeah, inguinal, right? I think of, this is usually for men, inguinal, right here. You're lifting, squatting, like all that pressure. Pop on through. What else? Femorals, inguinal, umbilical, ventral. Yeah, right up here. Anywhere there's like a weakening in that muscle wall, this can happen. Okay, keep going. You're doing awesome.
Manifestations, tachycardia, abdominal distension, nausea, vomiting, pain. Fever.
Yeah, especially if it's incarcerated or irreducible.
Diagnostics would be just the physical assessment, so if something is clearly protruding or do imaging tests like CT scans or ultrasounds.
Right. So is this that it's coming through the skin, like evisceration or dehiscence? No, you don't actually see the intestine because the skin is still there, but you see it underneath the skin.
Yeah.
That clear. Okay, so it's not like we're open. Good.
Management would be often surgery, so like herniorrhaphy, where you repair the hernia, or hernioplasty, where you use a mesh to kind of reinforce that.
Yeah, little cover.
And then a binder can also be placed if they can't have surgery. For nursing management, you prepare the patient for surgery, watch for signs and symptoms of infection, and you try to prevent surgical complications and splint the surgical area. And then assessment, it would be examine the protrusion, assess for pain or strangulation, assess the characteristics of pain, signs and symptoms of infection, and monitor eyes and nose.
Okay.
Nursing diagnosis would be impaired physical mobility related to pain caused by hernia as evidenced by grimacing and pain rating of 6 out of 10. Risk for infection related to surgical incision or tissue damage.
For interventions, we have give pain meds, check vitals, encourage walking and deep breathing exercises, monitoring bleeding and drainage characteristics, and then changing their dressing if needed. And we would teach them that coughing is discouraged, pain management techniques, signs and symptoms of infection, and that if they have a risk of hernia with heavy lifting. And then evaluation, patient has decreased abdominal pain and no protrusion present. And then distinguishing information is a visible protrusion.
Yeah, yeah. So when they go home after surgery, we want them to be careful about picking up heavy objects. So we usually limit that to less than like 10 pounds for the first couple weeks. You know what that means, because it's not like, I don't know, it's not like a weight that you're carrying. It's like, okay, think of like a 5-pound bag of sugar. Something like tangible that they can understand. We don't want you to do 2 of those. So if you have a child at home who weighs 45 pounds, not gonna be picking them up, right? So heavy lifting, binding, coughing, we want them to cough and deep breathe, so these people are going to splint or put a binder on. Okay, so have a pillow against that surgical site so it just doesn't pop right back out. But we do want them to prevent atelectasis from happening. It's good getting them up, getting them moving, limit, yes, abdominal pressure. Okay, good job. You have a question?
Yeah, so when assessing a patient with a hernia, all of the following are manifestations except A, visible protrusion of the intestinal contents, bradycardia, pain, or fever.
What would we not see?
Bradycardia.
Bradycardia. Awesome. Okay.
Then number 2, when should a patient go to the doctor for their hernia? Select all that apply. A, they are experiencing nausea and vomiting. B, inability to defecate or urinate.
Seems bad.
C, severe pain in the affected area. Or
Yes.
D, fever.
Whoa. Uh-oh. What am I supposed to be seeking? Let's say all of those. Is that right? Okay, okay, all right. You all good? Okay, nausea, vomiting, fever, pain, and what was the other one?
Inability to defecate.
Oh
or
yeah,
urinate.
geez, no urinating, no defecating, we got problems, yeah. Okay, everybody good with that? Good job, hernia people. The nurse is preparing a discharge teaching plan for a client who has an umbilical hernia repair, which is following what the nurse included in the plan. Restricted pain medication. Maintain bed rest, avoid coughing without splinting. Irrigating the drain. Did we say anything about drain? Okay, so get that out of there. We restrict pain medication. No, but we are getting a little bit cautious with our opioids because it can cause constipation. So if they're on opioids, give them stool softeners to help them move things along. So what do you think? See? Yeah, good job. So smart. Good job, people. Okay, inflammatory bowel disease. That's my 15/8. Is that right? Okay, tell me about inflammatory bowel disease. You guys had Crohn's. Okay. These are often misunderstood or confused for each other. So you know I'm going to ask you a question to distinguish whether you know the difference between these two. So lay it on. What is Crohn's?
Chronic inflammation that affects the GI tract from the mouth to the anus.
Okay, that's a distinguisher from the mouth to the anus. All right, because ulcerative colitis is
Usually just a large.
just the large intestine. So that's a distinguisher. Okay, awesome. Keep going.
It can become patchy in different spots, which is also different because usually it's only in one spot.
Good job. So patchy, like cobblestone appearance. If you went down for a scope, I would see like, ooh, nice tissue. Ooh, inflamed tissue. Ooh, nice tissue. Ooh, inflamed tissue. All the way through, you could see that. Okay, for Crohn's, But ulcerative colitis, it's just gonna be your lower intestine, totally inflamed. Okay, good job, keep going.
And then the pathophys is the exact cause is unknown, but it is thought to be caused by genetics, environment, or an overactive immune system.
Yeah,
Manifestations, Crohn-specific manifestations are soft, semi-liquid stools that don't usually contain blood, and then pain in the right lower quadrant.
wait, that's all good. Right lower quadrant. Okay, that's not really this, okay, yeah, it could be. And what did you just say? It does not have,
Doesn't usually contain.
okay, does not usually contain blood, whereas ulcerative colitis usually has pus and blood. And you are defecating more frequently, more liquidy stools, right? Okay, good job.
And then other symptoms like cramps, fever, weight loss, fluid imbalances, malnutrition, anemia, and then delayed growth. And then diagnostics of colonoscopy.
Yes, yeah, scopes, right? So they can do an upper endoscopy and they can do a colonoscopy to see the whole tract. Good, and we can have issues with growth, malnutrition, anemias because of malabsorption. Right? I think it's somehow related to autoimmune inflammation.
And then management of this could be, can you manage corticosteroids or immunomodulators, like you were saying? And then to decrease inflammation, and then surgical options are bowel resections or ileostomy, depending on the location of occurrence.
Yeah. Of course, not ileostomy here, so good job. Nursing diagnoses.
Imbalanced nutrition less than body requirements, dysfunctional gastrointestinal motility, diarrhea, deficit knowledge regarding condition, nutritional needs, and prevention.
Yeah, and probably older self-concept, we're getting ostomies put in. Yeah. Okay, good. Questions?
We had a patient with Crohn's disease is asking about possible treatments for managing their disease. The nurse would be correct to say all except use of corticosteroids, bowel resection, ileostomy, was
Cholecystectomy. What is that? I'm talking about a gallbladder removal, yeah. Okay, so that's the answer. Yeah. Good. Awesome. One more.
all side effects to Crohn, or all are side effects to Crohn's except diarrhea, reflux, weight loss. And
Say it again.
all are side effects to Crohn's disease except diarrhea, reflux, weight loss, and anemia.
What do you think? That in person, if I was taking that test, I would check reflux. Okay, all those other things you expect. Okay, a male client is recovering, good job. Recovering from an ileostomy that was performed to treat inflammatory bowel disease. During discharge teaching, the nurse should stress the importance of. Okay, I want you to think where an ileostomy is. Where is that? Ileum. Are we talking small intestine or large intestine? Small, okay, so what kind of output do you expect from an ileostomy if I had that portion of my intestine brought out? Would it be solid formed stool? Like a sigmoid? No, this is going to be continuously draining liquid. This is a very challenging ostomy to care for because it is constantly draining liquid. So we're going to increase fluid intake to prevent dehydration. Wear an appliance pouch only at bedtime. Now, consuming a low protein, high fiber diet. Taking only enteric-coated medications. So which one? A, they're great risk for dehydration and electrolyte abnormality. Awesome. Okay, good job, people. Thank you so much. I'll see you on Wednesday. I'll see you tomorrow. Get a little picture taken outside after. Thank you, thank you. So, Thank you. Oh, right here. Right now for like 10 minutes. Okay, no phones out, just jot down your concepts. If you have questions, let me know. You want to do that now? Anybody that's available? Yeah, thanks, Miss Megan. I'll open it up. Oh, no, it's pointing at me. Yeah, if you want to do it now, you can. Right.
If I try to- nothing. I'm.
So I will, yeah.
I have to stop the call. And then I have a meeting at 4. Not doing anything. Okay, thank you. You're muting us. Yeah. What? I think she's out.
I'm actually kind of excited today.
Okay,
Over the
I'm
wall.
gonna open it up now. No taking screenshots and no taking pictures. Just jot down the concepts for me. If you have questions, please let me know. Otherwise. Let me know if that I'm in trouble. Okay. Can you? New option. 10. Right. Okay, all good?
Yeah.
Can you see? Miss Sammy, I'll see you right. Six. Thank you. Increase. Any questions, worries? Ask now, I want you to know it now, for real life, not just for the final.
Car accident. Was it because of the grading? That we have been creating? Because there was a trip had to do with the kidneys have damage to their stomachs. So. With this. Contrast. Okay. I was thinking, yeah, so I was really hard to get. I thought that was respiratory hospital.
It starts as alkalosis.
That is.
And then it becomes.
I just take one picture. I've heard. Why does it start?
So interesting.
Yeah.
Well, but then when they first ingest it. That's it from bloodstream. So it makes it more acidic than all of these.
Okay.
Not so interesting. I don't know what else does that.
Yeah.
I'm sure there's others, but I am like, that's interesting.
Okay, that makes sense.
Yeah.
I just have one more. I just have a couple more things, so just give me 1 second.
Okay.
I don't have any
Yeah,
questions.
okay, yeah,
I
no
just
worries.
have like.
Like, and I'm the only one here. No, it's good to ask questions, really, and go through it.
Thank you.
Yeah. Any other words?
There was one more about, like a patient with AKI, and they have, they're like urinating 4 liters per day. I put crackles, just kind of thinking like fluid volume excess. Cause isn't that like the sound that
Yes.
you would hear for that?
Well, if they're diuresing 4 liters a day,
Yeah.
you would not expect.
I guess, yeah. 'Cause it's
Right?
not like lungs.
Right, you would not be fluid overloaded. You'd be worried about the opposite of that, being dehydrated,
Oh, okay.
right? I think that's what the question was asking. So did you get that right? Because it was like, what would you not expect?
No, I didn't put.
Oh,
Yeah.
because that's, remember the oliguric phase? Yes, because they're not putting out urine. They
Oh,
could be overloaded, but once they start diuresing like 4 liters
Okay.
a day, that's more
I think
than
they-
expected.
Get confused with that, cause I'm like, oh, well, if they're urinating a lot, then they must have a lot of fluid, but no, it'd be opposite.
Yeah. Right. Yeah, what would you not expect? It's because they're putting out all that fluid, but you're like, well, they must have a lot of fluid to be putting out that much fluid.
Okay.
Yeah,
That makes sense.
good job.
Thanks.
Okay, man, have a good day.
Thank you.
What do you have?